Dr. Koku Awono-Williams. Dr. Williams is a public health physician, is a PhD epidemiologist, and is the director of policy planning, monitoring, and evaluation at the Ghana Health Service. He has a teaching appointment at the School of Public Health at Columbia University, and he has several publications, and he has spoken at different universities and different forums in the US. I am honored to present him and all the other speakers, and I will give the introduction ahead of time. So over to you, Dr. Awono-Williams. Dr. Williams? Hello? Okay.
Thank you very much, Prof. Thank you so much for the kind introduction. Can you see my slides?
Yes.
All right. Trying to get this right, yeah. So thank you very much for the opportunity to make a presentation on a brief overview of Ghana's COVID-19 situation, basically to highlight some of the preparedness measures, the responses, what has been some of the community engagement, and what generally has been the effect of COVID on the health system. Let me say that in terms of the COVID, we in Ghana confirmed our first positive case, 2 cases as far back as March 12. What is interesting about this is that these 2 cases were the index cases, and they were all imported cases, one from Norway and one from Turkey. As at yesterday, we have recorded as a country over almost 44,000 cases. We have about 41% of the 41,000 or 42,000 recoveries. And we have recorded as of yesterday 270 deaths as a result of COVID-19. Ghana is divided into 16 regions, and we have so far recorded cases in all the 16 regions of Ghana. And I will show you where we have the epicenters are. In terms of activities and actions and directives, there have been various directives led by the president of the country to mitigate the spread, as well as provide guidance and protocols for adherence to COVID safety protocols and preventive protocols. And these activities were also enforced, but then also had a lot of support from various institutions, especially the military and the police, in terms of adherence. Now, if you look at this table, our capital, which is the Greater Accra region, remained the highest region among the 16 regions for the highest number of cases. And then we have the Northeast region has recording the lowest number of cases. So currently we have 2 main regions, that's Ashanti region and the Greater Accra region, that are contributing almost 72% of the total cases of COVID in Ghana. And that also has implications for the mitigating measures. Now we have a dedicated website for coronavirus in Ghana, and this is how it looks like. Daily you can go there and look at the number of new cases that report, confirmed cases, number of recoveries or discharges, number of deaths. It can also show you in terms of gender, how many males, how many females were infected. So, and also within the snapshot map, you can also see where the highest or where the epicenters are. And you can go to that, go look at what is happening in Ghana. If you look at the comparison, comparing Ghana to either Africa or West Africa to the global picture, this table just shows the number of cases as against from Ghana as against what the contribution of those number of cases to West Africa and to Africa. And you can really see the number of cases, the number of deaths, the number of recoveries. In Africa, as of yesterday, we have about 1.1 million cases, almost 8,000 deaths, and 922,000 plus recoveries. And if you compare the number of cases in Ghana, you can also see how Ghana is doing in terms of COVID-19 within the sub-region in terms of West Africa compared to the whole of Africa, and what is the contribution of those cases to the global picture. Now, prior to COVID-19, before the first two cases were confirmed, there had been a number of important measures that were taken by country. First of all was the fact that the public health emergency or the healthcare system were activated. And then also all the passengers who were coming to Ghana were screened and either isolated or quarantined at the point of entry, all aimed at containing the spread. Then one of the most important things that was done was the establishment of the emergency operation center in terms of case management and coordination of activities and cases. And then of course, one important landmark in the management of COVID is testing. And therefore 3 main laboratories in the country were equipped that they can actually go to screen and test cases. So the question is, what has been some of the public health measures or response, to mitigate the further spread once that we have reported 1 or 2 cases as index cases? First of all was the establishment of what we call the National COVID Task Force, which actually is chaired by the President of the Republic. Below that was what we call the National COVID Response Team. And this team is very important because across the length and divide of the health sector in terms of regional, national, district level, all these various response teams were activated. Then of course, government in terms of preventive measures, the practice of social distance, the practice of hand hygiene, how to encouraging citizens not to crowd, avoid overcrowding, and then of course sanitation and surface sanitizers and all that. Then of course I said earlier that we have Greater Accra and Ashanti region as the epicenters. Then we had a partial lockdown of these 2 regions or cities for 3 weeks. Then all the airports and borders were closed. All public gatherings, conferences, workshops, funerals, festivals, political rallies, church activities were all banned. And then of course, we closed all the educational institutions, the secondary schools, the high schools, the training colleges were all closed. And then we also Ministry of Local Government and Rural Development was tasked to also do nationwide disinfection and fumigation of all the major market centers and public areas. And of course, the last one was that there was a command center and the Ministry of Information was designated as the mouthpiece for information and update on COVID. What are some of the major strategies that were embarked upon since cases, increase in Ghana? First of all was mandatory quarantine of all travelers to the country. There was enhanced surveillance, which is both routine and active. There was enhanced capacity to be able to test, both at the national level and at the regional level, if not at least the collection of samples for testing. Then there was a continued quarantine and isolation of potential cases. So there was self-isolation and there was mandatory isolation based on the situation. Then of course, one important thing was that the whole management was guided by data and the science to understand the disease dynamics and identify hotspots and predict potential hotspots. One of the things that was also done was the expansion of the number of treatment and isolation centers across the divide of the health system. Then we embark on aggressive contact tracing. Production of local PPEs became a major intervention because at the point in time, borders were closed, supplies were not coming in. So how do you produce face masks? How do you make sure that you get all these sanitizers for prevention? So there was a local production. And then of course, we have seen quite a huge effect on general hygiene, social distances, communication, behavior change in terms of, sanitation and that. Now the effect, one of the things that we have seen is the effect of COVID on other non-COVID services within the health system in Ghana. Okay, here we are doing normal things, and then COVID came in March. And then, of course, there was a lot of attention on COVID, and that invariably affected non-COVID services. We've seen some sections of health facilities that were shut down, and some services were suspended because, you know, of critical mass in terms of staff and all that. We have also seen some quite significant disruption in service delivery. We've seen a drop in OPD attendance. We've seen a drop in some of the RMCH services. Immunization, for instance, was down. Facility deliveries went down. Again, it's obvious, it's understandable. Of course, one of the things was the increased fear, stress, and anxiety among frontline health workers. Okay, high stress burnout, which, I mean, stress and burnout, which leading to poor quality of care, which already is an issue that we have been dealing with. And you can imagine that this basically will contribute to the indirect effect of the pandemic. And as at today, we have recorded almost about 2,000 health staff who are either infected, who are actually infected, either due to lack of, you know, required PPEs or non-adherence of safety protocols or any other reason. But that number is quite huge in terms of, if you look at our health workforce and realize that over 2,000 of them are currently infected. Now, one of the things is that what do we need to do, you know, to be done to improve the situation and prevent the further spread of COVID-19, as currently we're talking about over such a huge number of cases. Well, the establishment of the local production of PPEs and other logistics was very significant, and it's important that we continue that. We need to continue aggressive public education. You know, there are still people who unfortunately believe that COVID is not real, despite the effort in terms of education and all that. And we need to continue the mass testing. We should continue the isolation and the quarantine of people who are flying in and coming in. Currently, our airport is closed, but then there had been a gradual reduction in terms of the COVID. We have to continue to training and reprioritizing and mobilizing health workforce is very important. And now that we have over 2,000 health staff infected, it's obvious that many of them will also be afraid in terms of getting COVID. Then the other thing is that we need to also expand the availability of services by way of designating more hospitals to receive and be able to manage COVID cases. It means that training is important in terms of protocols and SOPs and all that. You know, one of the things that we are doing in the country because of the peculiar nature of most of our rural areas, also how do we explore, you know, the importance of telemedicine and telemetry to be able to mitigate against the spread and, you know, anxiety, reducing anxiety and fear. We need to also review our supply chain and stock management in terms of essential medicine, you know, and then address, as I said earlier, the burnout, the stress. So the mental health needs of our health staffs, even not only that, but also citizens and their relatives who come to hospitals and found out that their loved ones are infected with COVID. And of course, we also need to, the whole area of management in terms of clarity of rules and responsibilities and the coordination mechanism that also needs to be improved. The effort is put on also making sure that we improve community engagement. You know, our structure is that we have about 60% of our population that are living in communities and that needs, you know, a lot of education and information to make informed and right choices. Okay, so the whole area of risk management, risk communication, community engagement has become very important because we believe strongly that community engagement and risk communication, if we use that approach, if we apply them, will make it easier for us to be able to do better job at COVID control, I mean prevention and you know, in terms of contact tracing and stigma reduction. So it's a combination of effort at the community level in terms of community engagement, okay, using all the structures, you know, and you know, all the resources available, and also the effort at risk communication in terms of how do you get the media involved in playing its role in terms of informing community? How do you set up information monitoring system at the various levels so that people can be aware of what is happening? Finally, knowing that Ghana has a very strong, unique public health system, which is called the CHIPS program, one of the things that we are looking at is what to be the role, or what role would CHIPS play, what role will communities play in the fight against COVID? Because it's important to do that. So we think that using already what is in the health system in terms of the structures, that is already, we can leverage on those important structures, use community structures for health education and risk communication management. We have to employ the knowledge of community health officers, CHOs, who are already in the communities, who are already mobilizing the community for health action, to do a number of things in terms of COVID mitigation, contact tracing, education on social distances, wearing of masks, and other safety protocols. We also need to use the village health volunteers and the community health management committees that we have in the community so that they can also play the important role of mobilizing communities for education and information. And finally, we think that, and that is something that we are also exploring, that could the chip zones that we have in the communities be places where community samples can be collected for testing. You don't need to travel from the village 40 kilometers, 20 kilometers to a health center or hospital designated for sample collection. If community health workers, CHOs are trained, they can be able also to, use their centers for sample collection and then and testing. So in a brief, this is the overview of the situation in Ghana that I'm happy to share with you. Thank you very much. Over to you, Prof.
Thank you so much, Professor Dr. Awono Williams, who is a professor because he does teach and gives presentations like this across the world. And I'm going to move to Dr. Adeyemi Johnson. So I'm going to do his introduction. Dr. Johnson, can you unmute yourself that you're ready? And Dr. Johnson?
Yes, I am ready.
Great. I'm going to allow you to share your screen. Do you have, or is that not necessary?
I have a few things I want to
share. Okay, we're going to give you the opportunity to share your screen that way. Okay, it's already done. Great. So I will start with my introduction. So Dr. Adeyemi Johnson is a cardiologist by training, is a US trained cardiologist that has several decades of experience. He is the founder, co-founder of the First Cardiology Medical Center in Lagos, Nigeria, which was the first private hospital in the country to be registered and authorized to manage COVID-19 patients. He has extensive experience. Not only is he a cardiologist, he's a pulmonary expert. So his services are much in demand in Nigeria at this time. And I'm going to hand it over to him. Both him and Dr. Awono Williams' CVs I've kind of paraphrased because I just want to give them more time to speak. And over to you, Dr. Johnson.
Yes, thank you. Good. It's afternoon here. Good afternoon and morning for those of you over there. Sorry, I was in a bit of a hurry. We had some issues to deal with just before this started, so I'm a bit rushed. But basically, if you asked me in December if I would ever be involved in infectious diseases, I'd laugh. I'd say I'm a cardiologist. I'm an interventional cardiologist. All I do is stents, heart attacks, and stuff. But somehow, I am in the forefront of this COVID-19 disease, which has come to affect all of us. I don't think any of us expected this several months ago. So why is a cardiologist involved in COVID-19? And why am I speaking at a seminar or a webinar that is mostly about public health and policies and things like that? Well, let's start from, I'm going to give you more of a clinical perspective, not the public health, public policy perspective, although what the previous speaker talked about Ghana applies to us a great deal. We're very similar, but I will have to commend Ghana because I think they have one of the lowest mortality rates in the world. And I have to commend them for that. Whatever they're doing is working, and I'm proud of what they're doing. So cheers to Ghana. Now, we got our first case on the 20th of February this year. It was from a foreign individual who came in to do some work, and he was found to have COVID. And shortly after that, we shut down the airport. And at the beginning, most of our cases were people who had contact with people who went abroad. That's how it started. And our mortality then was quite high compared to what it is now. That's probably because the disease was new and everybody was trying to figure out what was going on. Now, looking at the statistics, most of our cases are 74% are what they call unknown exposure, which probably means community spread. So it's no longer people going abroad. It's no longer just the affluent who have gone abroad and brought this back. Because in Nigeria, as far as most people were concerned, this was a disease of rich people. It didn't concern the general public. So they really didn't care about it. And I'll tell you, even in our clinic that dealt with COVID, many of the staff did not believe this thing really existed. But until they started seeing sick people and started seeing tests that were positive, then they realized, well, this thing is here. It is not imaginary as many people think. But I can tell you this, in Nigeria, the average man still thinks this is some kind of game the government is playing. They don't really believe it's sick because they don't see people dying the way they've heard people die in other parts of the world. And that brings me to the mortality in West Africa or in sub-Saharan Africa as a whole. As all of you know, our mortality is quite different from what we see in the Western world, especially in places like Brazil, United States, United Kingdom, where they have up to a 10% case fatality rate. In Nigeria, ours is about just under 2%, 1.9. In Ghana, it's much less than this. In South Africa, that has most of the cases in Africa. I don't have the exact numbers, but South Africa has the largest number of cases of COVID in Africa. But their mortality is not the highest. Mortality is highest in, I think it's in Egypt. So we try to understand why is this so? I'm not sure. Now, one reason I have that we've discussed this extensively in many different platforms is our age. The median age in Nigeria is 19 years old. In the other developed countries, it's more in the 30s and 40s. So younger people are getting it here. They're probably not getting as sick. And so the mortality in those people is low. Now, the concern is now that we have started to open up, what's going to happen? Because the elderly, the people who are at risk are all staying indoors. They're really trying their best not to get exposed, most of them. And the concern is when the country opens up, are we going to get a surge? But an interesting number to look at is our cases. I don't have the slides here, unfortunately, but the number of cases is going down. We peaked at about 700 a day. Now we're down to 200, 300 a day. Now, a lot of people would think, oh, maybe we're testing less, but no, we are testing more, but the cases are coming down. Now, are we going to mirror the US and everybody else where it goes down and then there's a secondary surge? I don't know. We're hoping not, but I don't know. What are the other possibilities for our low mortality rate? There's this business of hydroxychloroquine, which is somewhat controversial. The studies have not yet definitely shown that it's helpful, but I can tell you almost everybody in Nigeria takes it. Once they feel sick, they say, okay, it might be COVID, I'm taking hydroxychloroquine. If it helps or not, I don't know, but it's something we've got to consider. There are a few studies going on in Nigeria now to tell us if this helps or not, but it'll be interesting to see. Now, are we more immune? I don't know. Or is the virus mutating and becoming weaker in West Africa? I think that's a possibility, but I don't have any proof of that. Okay, so let me go to the clinical stuff briefly. The way it started, as you know, Lagos was the epicenter, it still is the epicenter. The government set up isolation centers and everybody who tested positive had to go to an isolation center. After a few weeks, all the isolation centers were full and it was costing the government a lot of money. And as you know, we are a third world country. We don't have that. We don't have resources like that. So we had to change our strategy and ask people to isolate at home. And now the isolation centers are not as busy. But everybody's isolating at home. And I believe those who get it actually do a good job of self-isolating, because then they realize this thing is serious. I don't want my mother or my father to get this thing, so I better stay at home and self-isolate. Then my part is the ICU. Now, some of you might have been seeing the statistics that were being thrown around when this started, that there were only maybe 100 odd ICU beds in Nigeria, maybe 50 ventilators that were functioning, and we were going to need so many thousand ventilators, and everybody panicked, and everybody started buying ventilators and from all over the world, and that's what happened. But we were the first ICU that tackled COVID, and that's simply because we saw what was going on around the world. We knew we were one of the top ICUs in the country. We're not big. We have 10 beds, 10, 12 beds, depending on how we configure the ICU. And we said, look, let's get ready. This thing is coming. We are not going to escape it. So we got ready. We got the architects to separate out the COVID section from the non-COVID section, and we got ready for the ICU work. And that's how we started. And then the government now accredited some other hospitals. But I can tell you there were not more than 20 ICU beds in Lagos at one time. And that is in Lagos for a population of 20 million. So at the beginning, we were all stressed and everything was packed full, and people were dying waiting to get into the ICU. Now, the mortality has gone down, incidence has gone down. None of the ICUs is overworked at this time. None of us is, we are not full any longer. So I'm not sure what is happening, but I like it. And I hope it continues this way and we don't get a secondary surge. Although we're getting ready for it since everybody's, we're reopening. Then what could have affected our mortality? We started using steroids early. Remdesivir is now available. Now remdesivir costs an arm and a leg in Nigeria. We get it for about 5 million naira for a complete dose for a patient. That's about $12,000. That's a lot of money for anybody. That is a lot of money. But that's what we have to deal with. Now, WHO is talking about getting us remdesivir for research, and that will reduce the cost to us. But basically, in a nutshell, ICU was busy. It's now less busy. Incidence is going down. And I think my prediction is it's not going to be as bad in Africa as everybody predicted, for a variety of reasons, many of which I do not know. And I'll stop there and wait for the questions after this. Thank you.
Thank you so much, Dr. Johnson. I haven't seen Dr. Fowler sign in. So if you're out there, Dr. Fowler, please unmute yourself. If not, I will start with the questioning myself, and then we'll move on to the questions because we have quite a few of them for both Dr. Johnson and Dr. Awono-Williams. My question is mostly directed at Dr. Johnson because of the issue that I brought up in terms of the mortality being quite low in most African countries. The case fatality rate has been great. The spread has been low, mostly because most of the countries went into total shutdown, and they've been very proactive. But even the case fatality rate for people sick has been low. And you alluded to using hydroxychloroquine and the age. But could it also be the fact that the overwhelming level of infectious diseases in our countries are so high that at the end of the day, people have some kind of general immunity that is acquired against different viruses already because their body is generally more exposed to infectious diseases?
Oh, yes, that is certainly a possibility. It certainly is. But we've got to study this thing to find out if that's what it is. And it might also be that the virus is competing with other contagious diseases in Africa, and the other diseases tend to be a bit more serious than COVID, and maybe COVID has not been able to set itself as well as it would like to. But yes, the other infectious diseases are there. And the one thing is this that I think about is our, what do you call it? Well, I'm losing my train of thought here, but the age you die, what's that called again? The average age you die.
Life expectancy.
Our life expectancy, thank you. Our life expectancy in Nigeria is low. I think it's about 48, 50 years old. And it might be, and you have to remember, most of those people die in their infancy. So those who have survived past that level might actually have more resistance and are healthier than the average person otherwise would be. It has sort of selected the healthy people out. Another interesting thing, though, is we had several 90-year-olds admitted to the ICU. They all survived. You would think that they would get really sick, but they got sick, but they all survived. They all walked out of there without going on the ventilator. So there's something to be said for having survived the early years in a third world country. And then when you get old, you're already selected to be one of the immune stronger individuals.
Thank you. I'm going to hand over the questioning to Rebecca, who is my colleague and the Global Research Institute, and helped set up this fantastic webinar. Rebecca, I'm going to hand over to you for the questions.
Fantastic. Thank you, Iyabo, and thank you so much to our guests. It's been really terrific to listen to your kind of frontline experiences. I've been skimming through the questions and looking for the themes that are emerging, and I wanted to start with something that you both touched on around, or perhaps only one of you touched on, but around skepticism and denial of COVID-19, either as a serious illness or as an illness at all. And that's something that we're seeing around the globe. Certainly here in the US, that has been a challenge in the response. I wonder if you could talk a little bit about how public health officials in each of your countries or in West Africa more broadly are combating skepticism and denial of the illness to encourage people to take effective public health precautions.
Well, thank you very much. Let me start, and probably Professor Yemi can come in, Johnson can come in. I think it's obviously, it's something that is expected in many situations when you have situations like this, when you have a new pandemic and you see people. I mean, one of the things is for us in Ghana, I think that one of the things that we are focused on is to make sure that we use the science and data to actually educate the public, for them to understand and believe that this is a reality. And it is expected that there will always be skeptics. I mean, there will always be people. I mean, I was talking to somebody the other time and they asked me, "Doctor, do you think that COVID is real?" I said, "Oh yes, it's real." See, but I have not seen anybody close to me that I know who has died. And all the people who are dying, nobody knows who they are. Okay, we report number of deaths. Okay, yesterday, for instance, we reported nine deaths. I mean, nobody has come out to say that this is my relative who died of COVID. So people who have that kind of skepticism in terms of, believing whether it is true or not. I think that what it behoves on us as public health physicians and, to be able to just make sure that we actually do the proper education and get people to believe, to understand that, it is real. You cannot get every 100% the population believing that is true. I mean, somebody also said that, look, since COVID, he has never heard of anybody in his community or around his community who said died out of COVID. Okay, so I think that is we have to find a way to deal with this skepticism in terms of people who don't believe, and that is the challenge that we have as public health practitioners. Yeah.
Okay, I don't think I can add much more than what Kuku said just now. It's the same problem here. But I would say amongst the middle class and upper class, I think there's now they now believe that it does exist. And that's because, unfortunately, we've had a few big names not make it, and that gave the COVID a lot of publicity when some politicians and some other politicians especially did not make it. It gave me negative publicity, but it also made people understand that yes, this disease is there, and but I still think it's for the big guys, not for the average people. But I think one of the things that has reduced or has helped is the churches. The fact that churches and mosques were shut down, it affected everybody. So because everybody in Nigeria goes to church, everybody, or to the mosque. And for them not to go and for the leaders to say, look, don't come to church, there's COVID, they must have realized, okay, this thing is real. We're not going to church. We're having to do Zoom. Or those who don't have Zoom know that, well, we can't go to church. And there is something going on. I think in West Africa, or at least in Nigeria, if you want information to spread, you do it through the religious institutions, and it will spread. So I think that's one of the things that has actually helped. Thank you.
Thank you to both of you. On a different theme, I wonder if you could each speak a little bit about testing and sort of the saturation of testing and the testing pipeline. As you, I'm sure know, that's something that has been a challenge here in the United States, but we're not alone in kind of having difficulty producing enough tests and making sure that they're being turned around quickly enough to make a difference. So can you speak a little bit both in the really concentrated, dense urban areas as well as more rural areas, what the testing regime has looked like and whether you feel that there's adequate tests or what strategies have been employed to make sure that enough people are getting tested?
I'll let Koku take that first because I have a different opinion on testing.
Thank you, Johnson. Well, that's a very important question. For the case of Ghana, we had initial challenges of logistics. Since the first cases, March 12, 2020, hit us with isolation centers, PPEs, testing was a major discussion. And one of the things that we had, then also, of course, where are you going to test? Do you have enough laboratories? Do you have enough logistics for testing? So we're not fortunate. We have one major research institution, the Noguchi Institute was there, so they started the testing. But then the epicenters were also in the urban areas. They were in Accra or Kumasi. These are our largest cities. So that's where the concentration, we started testing in Kumasi, and then also first in Accra, then later in Kumasi. And then over time, we learn by doing. We learn as we understand more and more. We learn more and more as we improve on the protocols, training of health workers, logistics coming in, and then over time, and of course the evidence coming in terms of what kind of test to do, okay? So the PCRs and all that, from national level in terms of the two epicenters, we now move to the regional levels, and that is where we are now, that every region now can test. Otherwise, you have to initially take a test, call a sample from the northern part of Ghana and travel all the way to Accra to test, so the limitations were there initially. And then of course, then there are new technologies in terms of rapid diagnostic tests. I will not go into efficacy and all that, but those are available, and that opened up the space now for more and more people to be tested. But again, the test also has limitations. We are not doing mass testing, okay? We are doing targeted testing, people who are coming to contact with the people who are suspected. And then of course, when they are suspected and they are tested, the contact is traced and the contacts are tested. So we are still doing, I won't say that we are doing mass testing, we are doing limited testing. And we are learning as we are moving on, and the fact that we have testing centers in the regions has expanded the scope, in terms of the availability of the test. But I can confidently say that the test kit is still a challenge, availability of test kits, even though effort is being made to improve its availability, but that is still a challenge. That's what I would like to say about the whole idea, the whole thing about testing. But work still in progress. I mean, we are improving as we are working on COVID, learning more and more what needs to be done, and also looking forward to some of the new technologies that are available for us to also employ in our country.
Okay, I have this is my own personal opinion about testing. I don't think we can afford to test the way people say we should test. I just don't think we have the resources to do it. It's expensive. And if we spend our whole healthcare budget on testing, what are we going to achieve? Now in Nigeria, we've tested less than 400,000 people. We have a population of above 200 million people. And the US, they're crying. I think they've done 60 million and they're saying they're not testing enough. I frankly don't think we have the resources. We do not have the money. This testing is expensive. It's not like a malaria test that's simple and quick. It's expensive. This PCR is expensive. The antigen antibody tests that are quick, they're not cheap, and there's still a big question mark as to their accuracy. So my opinion would be test only those who need to be tested. That is, people who are sick, who have symptoms, and you want to decide how to treat them and where to put them. I think people should do quick screening tests when people are admitted to hospital, so you don't mix possibly infected people with non-infected people in hospital. But other than that, on a community level basis, I think everybody should assume the person next to him is a potential COVID patient, and protect yourself. I think for us, we do not have money. We are a third world country. We are going into a deep, deep recession. Whether anybody likes it or not, the whole of West Africa is in trouble economically. I don't think we can afford to spend all our money on testing, because I am not sure the yield from testing is going to be that much. I think the basic thing is still back to basics. Protect yourself. Prevention. Everybody wear a mask. Adhere to social distancing as much as you can. And when the churches resume, social distancing. Things like that. I think that's the best we can do in this part of the world. We can't test everybody. We don't make these testing kits. And it's just not practical. Thank you.
Dr. Johnson, building on your comment about the cost of the test and the financial burdens that would exist to test really widely, we saw a couple of questions in the chat box about the financial implications of the COVID crisis, and wonder if each of you could speak a bit, just to the best of your ability, about the kind of ripple effect financially for your governments of having this crisis pop up.
Okay, I can speak for Nigeria and specifically for Lagos State, not as a representative, but just reading the news and seeing what's going on. The COVID pandemic, as it relates to us, has really taken a big toll. It really has. As WHO suggests, you're supposed to have 15% of your budget allocated to healthcare. Now in Nigeria, maybe it's 4% of our budget allocated to healthcare. I can tell you almost all of that is already wiped out with this COVID thing. So we have a lot of other diseases that we have to deal with. And 60 to 70% of people in Nigeria pay for healthcare out of pocket. Then there's no jobs. The economy is going down. There's a worldwide recession. This has really, really affected us. And unfortunately for us, we import everything. We import almost everything. 99% of what we use in healthcare is imported. So this has really, really hit us hard. And we're going to start to see the effects quite soon. Like today, what delayed me was I had to deal with 2 heart attacks. The truth is, while COVID was on, people didn't come in with chest pain. They were all scared of coming to hospital. So now they're coming in because they're too sick. So they come in extremis, and this is going to have a ripple effect on many other disease processes, having babies, other things like this. So that's why I don't think we should spend all our resources on COVID, because no matter how it happens, it's not going to account for more than 1 or 2% of our mortality in in the country. There's going to be other things that we have to deal with: heart disease, hypertension, strokes, cholera, Lassa fever, things like that. So yes, this is going to affect our healthcare going forward, at least in the short term.
Dr. Williams, you want to add something to that on the cost in Ghana?
No, I think that Dr. Johnson has made a very brilliant submission to that. I think the Ghana situation is the same. I mean, the socioeconomic effect of COVID on nationals, the whole national systems, on health system, education, tourism. I mean, currently we have our airport closed, so you can imagine revenue is not coming in. We have to, I mean, one of the effects is that as soon as we have the COVID and then we try to start looking where to go, I mean, a lot of the programs that we have to divert resources. Maybe resources that are meant for a particular program has to be put in COVID fund. You know, government has to go to the World Bank and IMF to take additional, you know, loans to be able to dedicate those funds to COVID. There's a lot of vulnerable people in the society that had to be fed because, you know, the lockdown, the 3 weeks period, a lot of money has to be, you know, spent on people to feed people. You know, the whole idea of the whole issue about, you know, the human resource training for health, you know, creating isolation centers. You know, so the effect is huge. It's huge. It's huge. And Ghana, we are doing between 3 and 4.5% of GDP to health, and I suspect that is going to go down because there's not enough taxes coming, there's not enough revenue, so government has to go again and borrow money. So in terms of social, economic, and all that, I think that is, I mean, there's no doubt that the effect is huge, and those effects will be felt for a long time to come as we go through this process, this phase of currently we are seeing some restrictions in the COVID measure that have been taken by government. We've seen the opening of the churches, but then 1 hour of worship. We've seen some reduction in some of the limitations. And so as that unfolds, again, I mean, business have closed down. A lot of people have closed down, and schools have closed down. You know, so it's a huge effect on the economy. And I mean, and I think that with time we'll actually be able to measure the full scale of this. For now, that is the situation. Yeah.
So maybe we'll go to our last question, Rebecca.
Yeah, absolutely. There have been a number of questions in the chat related to the political environment and how it's being impacted by COVID-19. And so 2 threads, and pick up either or both of them, whichever is interesting to you. One question was about the potential rise of xenophobia as a result of the disease coming in from other places, and whether you're seeing that as an ongoing trend, or whether you think that that is not as much of a concern in West Africa or in Ghana and Nigeria specifically. And then also, kind of what is the impact of banning large gatherings and political activity on democracy? Is there a chilling effect there, and what does that look like? So, as I said, either or both of those threads related to the kind of the political and social environment.
I will start, then Dr. Joseph will come in. Just a quick comments on both. Well, we started with 2 imported cases, and soon after that, we started seeing community cases. Okay, and currently, I mean, all 90%, 95% probably of our cases are community cases. So, but I mean, we don't have this whole issue about xenophobia and all that, no. But people still believe that, you know, I mean, pro and against. I mean, if the airports, if the borders were closed early, even those 2 cases would have come in, etc., etc. So it's neither here nor there. I mean, the fact is that we're imported, one from Turkey, one from Norway. And then, of course, we thought that if we take all the protocol measures, then of course, then the beginning of the lockdown, you see a lot of people who are traveling also from the epicenter to to the communities because they don't want to be locked down for 3 weeks. And then we start seeing the cases in the communities because, you know, people have traveled. So where did they get the cases from before they move? If we have only 2, was it that there are already been community cases before, you know, the 2 cases that were picked, you know, as important cases? We do not have a xenophobia kind of thing in Ghana. No, that is, fortunately, we don't have that. So people are taking in their stride. The second thing is the politics and banning of large gathering. Beginning, everybody accepted the fact that no, that is one of the measures to mitigate against COVID. Okay, ban large gatherings, close churches, and everybody was for it. You go out, the period of the lockdown, you don't see anybody in the street. People, there are strict adherence to all that. Over time, I think people were getting fed up. Again, as the political season is coming now, people are also getting skeptical whether this is designed basically for one particular political party to take advantage of the other. And so you hear, I try to answer on the chat that it's quite an interesting debate. You hear the side of the ruling, you know, party or government defending because, and there's science evidence that, look, you need to ban large gatherings not to get infected or that. But on the other side, the opposition will say, oh, you are taking too much advantage, you know, of the lockdown or of the social gathering. Open out the space a little bit so that we can do our campaign. Generally, it's been accepted that, you know, of course, the government too has come up with the protocol in terms of how this year, because this year Ghana is going to election. We have our election in December, and so it's important. I think November 7 or December 7, I think so. So it's important that, you know, the politics also you know, heats up, and these debates are going on. That's what I would say. But you can never always take politics out of it, but you can also say that. No, that is the, yeah. So I'll shift over to Dr. Johnson to see what he wants to say about this politics and
okay, as far as xenophobia goes, I don't think in Nigeria there is that much xenophobia. I really don't think so. At the beginning, yes, anybody who looked Asian was looked upon with suspicion. But now I don't think that is really an issue. And the airport's closed anyway, so not many people are coming in. But there are a lot of foreigners already in Nigeria. And no, I don't think there's anything like that going on now. But what I do find interesting, very interesting, is this, I think I'd have to call it racism, whereby the UK, Europe, are telling us in Nigeria we have to go for 2 weeks quarantine when we come to the UK, where our cases are much less than theirs. Our mortality is much less than theirs. So I do not know what yardstick they're using to say we are the risky population, other than the usual thing that, oh yes, those guys from Africa, they always carry disease with them. And so we should be careful about letting them in. So that I find a bit, I don't like how that, it doesn't taste well to me anyway. Maybe I'm reading it wrong. But I think we should be worried about people from the UK and people from the US, Brazil, and India coming to Africa because they have the highest incidence in the world. And so I don't see why we should be the ones going into quarantine and then they're allowing other European countries to bypass quarantine. I think that's just, I think it's just plain racism. I don't see another way to put it. Now, as far as politics, luckily in Nigeria, we're not in our political season. So it's not really affecting politics too much, except in 2 states who have elections that are out of the usual sequence. So for most of us in Nigeria, it's not really affecting politics. It's just the church politics going on. Some churches feel they're being singled out by the government, but I don't think that's the case. I think most people agree we need to reduce crowds, and it hasn't affected politics yet. Thank you.
Thank you so much to Dr. Williams and Dr. Johnson. Thank you to everybody, all our students and all faculty that attended. We're going to save the recording, and also hopefully the chat will save too, and we can continue this discussion in other forums on campus and within the classes that the students from, I think, several classes were told to attend. Thank you, and hopefully this is the beginning of more interaction with African colleagues in different sectors of the health system. So thank you so much. Rebecca, do you want to just chime in?
Sure, I would only echo what Iabo said. Thank you so much for your time on behalf of the Global Research Institute and William and Mary. I want to say how grateful we are. I know you're both extremely busy, and Dr. Johnson, you were helping people recover from heart attacks immediately before this. So, you know, just say again, thank you very much, and we'd be delighted to have you again in the future. And we will be sharing this with students who I know are interested but were unable to attend today.
Thank you so much, Dr. Johnson and Dr. Winner-Williams. I know it's kind of late afternoon or early evening there. So hope you have a good rest of your day. And thank you so much. We're so grateful for your expertise and for sharing your time with us.
Thank you.
Thank you. Thank you for the opportunity.
Thank you.
Yeah.
Bye.
Bye.